Dear colleagues around from our pediatric webinar about the supracondylar humerus fracture. I think a lot of you have attended previous webinars, so you are familiar with this technique. First of all, I will introduce my colleague on the right hand side. This is the master of typing, John Dwyer. He will answer your question during my talk. That means during my talk, you can always online ask questions. But I have to inform you that we will answer online directly only the simple questions. He will collect questions from about the same topic. We will answer this at the end, and especially also burning questions, we will answer this at the end. Medias res, and let us start with our presentation. Perhaps you ask you why a webinar about different Kirschner-Wire fixation for supracondylar fracture. This is a simple topic, but as we know from the daily work, it's very often not so simple, and we see a lot of problems. And with this presentation, we try to show you how you can make it in a proper and good way that you end up in a good result. So, first of all, we came to the learning outcomes as always. At the end of this presentation, you should explain the indication for Kirschner-Wire fixation of the pediatric supracondylar fracture of the humerus. You should recognize the importance of anatomical fracture reduction in achieving stable fixation. And you should be able to explain the three different Kirschner-Wire fixation we will show to you. You should be able to describe the advantage and disadvantages of these three different fixation techniques. And you should recognize the potential limitation in relation to fracture pattern for each of these fracture techniques. Anticipate, prevent, and address complication associated with each of these techniques is also important. So, when we came to this fracture, for me and for most of us, there are three major problems. The first of one is, of course, the reduction. And the reduction very often is insufficient, and we get then not a good stability. The second major problem is the retention and fixation. As you can see here, if you see such a fixation with 7 Kirschner-Wire in place, or only 2 or 3 not in the bone fragments, you know, then you have not a good fixation. And the combination between the reduction and the fixation is the question of the stability, gives the question of the stability. And malalignment gives that very often, or results very often in a cubitus varus, as you can see here in this clinical picture of these very poor 2 boys. So, therefore, only a perfect reduction and fixation guarantees a perfect result. And we will focus on this, how we can teach this, how we can learn it, how we can do this, as you see it here on this picture. First of all, let us talk a little bit about complication. And we know from the literature, there are published overall 20 to 30% of complication, including, of course, the most frequent varus, or sometimes valgus deformity after healing, flexion or extension deficits, ulnar nerve injury, with the effect on cosmesis and function. So let us go step by step how to treat this fracture. For me, the first step, and is crucial, is diagnostics and the quality of the X-ray. That means if I have a bad quality of X-ray, as you can see here, the assessment is very difficult. So you make a bad assessment. Based on the bad assessment, often you make a bad treatment. As you can see here, if you have a high quality, good quality of X-ray, you can make a good assessment. That means classification of your fracture, and you will end up in a good treatment. So therefore, it's very helpful to have this AO pediatric classification for supracondylar fracture, which helps you in the assessment of this fracture. And this A fracture classification has an algorithm. You start at the beginning, what is the fracture complete or not complete? And for this talk now, we are speaking only about the unstable fracture, means type 3 and type 4, which I will show later. You can see or read or download as a PDF file this classification on this website, as you can see here. I let it for some seconds, perhaps you make a notice on. Okay, next step then, for me, very important, or sometimes the most important is the preparation of the patient. The arm positioning is crucial. Here you see on the left-hand side, on the free arm table, this is a left arm of a patient. But personally, in our clinic, I like to position the arm also direct on the C-arm. But take care that you protect your C-arm, as we have perhaps in our clinic such an adaptable table on the C-arm. This gives you a better view to the fracture, and you have to make a less manipulation of the arm. Here you see a detailed view of this adapted table on the C-arm, and it's radiolucent as well. And the advantage again is your arm or your focus on the elbow is directly always on the C-arm. You are in the focus, and you have not to refocus the C-arm to the correct position, what gives you much lesser irradiation time. Then the next point is how I should position the C-arm to the table or to the patient. There are two alternatives or ways to do this. Personally, I like the right angle position to the patient or the table, as you can see on this picture. But some of you prefer this longitudinal position parallel to the patient or the table, which allows you perhaps a little bit better access to the hand for reduction. But you will see in the next slide, you can do this also in the perpendicular way. Why I like to go in this way? What is the advantage for me for the right angle position? As you can see here in the middle, this is the position of the C-arm in a neutral position, and you see here the arm direct on the position. There is for us a law that the C-arm should rotate around the arm and not the patient should rotate around the C-arm. That means you see, as you can see here, or as you can see here on the left side, you can flip the arm to the right or the left side, that you have with less manipulation of the arm or less stress on the reduced fracture, a perfect view from lateral to medial or from medial to lateral. Of course, next step, step 4, is the reduction. And as you can see in this old drawing from Chandler's textbook, this is up to now the same maneuver. Longitudinal traction, reduction, flexion, pronation. And again, do not fix without to have a perfect reduction, and you have checked this reduction under the C-arm. Here you see that the original text, a close treatment of common fractures, and from inside of the book, the maneuver for reduction. And up to now again, it's the same maneuver to reduce this fracture. What are the steps of this reduction? First of all, longitudinal traction, as you can see here. And it is very helpful to have a watch or in your OR, and at least pull on the arm, stretched arm, 3 to 5 minutes. And to wait 3 and 5 minutes in the OR, it's a very long time. Therefore, it's very helpful to have this watch in the OR. Okay, then once you made this traction, you press on the button of the C-arm, only 1 second, one short shot, and then you see this nice picture. So the fracture is very nicely aligned and also rotational aligned. Why I can say it's rotational aligned, even in this AP view, there are some signs. First of all, you see a really AP view of the olecranon fossa. Secondly, you see a very well aligned radial as ulnar pillar. That must, this is a good sign that you have also a good rotational reduction. So sometimes it is not so easy to do this. So you have to correct the coronal plane to medial, to lateral, to medial, and you see here how to perform this with your thumb or your finger to do this, but always in a stretched arm, as you can see here. So then you check it also again under intensifier. So once you have this very nice position, then you have to reduce the flexion, the extension to a flexion, and to stabilize the fracture. That means maintain the correction of the rotation deformity by flexion of the elbow 10 to 15 degrees. And then, as you can see here, with the thumb, you press against the olecranon and the hand holds the humerus. And the other hand, as you can see here, rotates, means pronates the hand or forearm to give a higher stability and help to reduce and stabilize the fracture. As you can see here in these four pictures, again, longitudinal fracture, you see the hand on the C-arm and at the hand of the surgeon, and then you hyperflex and stabilize the fracture and check the X-ray. And here you see the X-ray then. In the lateral view, you have a very nice alignment, and in the AP view as well. But to read the AP view in a hyperflex position needs a good C-arm, and this is also the advantage to be direct on the C-arm with the elbow that you see this nice picture. And then, of course, here you see the alignment and the periosteum. Again, therefore, remember, as I mentioned before, C-arm rotates around the arm and not the patient around the C-arm. This is for me a kind of law. Okay, some fine-tuning in the reduction technique. That means you have to assess the deformity correction you get. Okay, first of all, coronal and transverse. You see again on the left side this very nice X-ray as you have seen before. You see the signs here, the fossa, olecranon fossa, the lateral and medial pillar were very well aligned. Next is here you see the clear AP view of the olecranon fossa. In the sagittal plane means in the lateral view you have the rotary line which must intersect the capitellum of the humerus, and you must have the correct angulation regarding the flexion, as you can see here. In the transverse plane, you see here, you have some sign, as you can see on this picture here, that you have not a well rotational correction. Why we can say this? You see in yellow the fracture line on the distal fragment, and you see in white the fracture line of the proximal fragment. And this line, the length of the lines are different. That means that you must have a rotational failure. Otherwise the line must be identical. So this is a rotational failure. So you have to correct this and not to accept this. Here you see the correction, and you see that now the white and the yellow line are correct. Sometimes, especially in oblique fracture, you have check the stability in this plane, as you see it here. Again, don't miss the advantage of the periosteum. In a typical 95% of all the fracture are extension type fracture, the posterior periosteum is still intact, and mostly also the radial periosteum is intact, as you can see here. The rupture we have here, and really the periosteum is your best friend for reduction and perineum stabilization. That means the posterior periosteum is like a tension band. You see here, after reduction again, maintain the reduction, and not only maintain the reduction, helps also to reduce the fracture in the first step. Very often you have to bone with your, and there is some trick how I can perineum stabilize this fracture in a good way if I have no additional help from an assistant. You see, after you get a good reduction, you hold the arm in hyperflex and pronation, as you can see here, and fix the arm with this band in this way, and then you trap the elbow, you sterilize the elbow. You know, as I mentioned before, we treat mostly in this way the type 3 and 4 fracture. What means type 3? Only as a short repetition. You see, this is a type 3 fracture, complete fracture, no bone continuity, but we have still some bone contact between the fracture and the planes. And in the type 4, we have also complete fracture, no bone continuity, no contact between the fracture planes. Here in this drawing, I will visualize the effect of the rotational failure during fixation or reduction. First of all, as a statement, the incomplete reduction of the supracondylar humerus fracture or failure to achieve stability in the transverse plane results in a rotational failure with apparent cubitus varus. What means this? You know, normally we have the lateral as also the medial pillar of the distal humerus. And even you have a slightly rotational failure, you have a good bone contact, and it is possible to bring a pin inside the bone with a good sufficient stability. But once you have a higher degree of rotational failure, you see the contact area is smaller and it's more difficult to get a good stability even you are using Kircher wire. And in case of 50-degree or more rotational failure after reduction, it's nearly not possible to fix this fracture in a proper way, and then you have only this crossing point here and the fracture will collapse, as you can see here. That means the pillar here collapses, this pillar goes up, and this gives rotation. Even you are in the plaster cast and you have perhaps a Kircher wire, but not in a good stable situation. And you can visualize this rotational failure as an assessment of your reduction on the X-ray in the lateral view. You see this nose, and this nose corresponds to the failure of rotational correction, as you see it here. Cubitus varus, as a result of the rotational failure and the collapse of the columns, modeling is excellent in the sacral plane. That means we have only a resorption or adaptation of this nose. And as you can see in this series of X-ray, here we have an incomplete reduced rotational failure or problem. Here in the plaster cast, there are no additional Kircher wire fixed in the bone to fix the fracture. In the plaster cast, we get more rotational failure and the collapse. After 1 year, you see the remodeling or the modeling of this nose, but not of the rotational failure and the resulting cubitus varus. As you can see now here, this is exactly the boy with this ugly elbow joint and this X-ray. So now we came to the 3 different techniques to fix this fracture. Operative option for the fixation. The first and the most common one is this crossed Kircher wire from below upwards to the proximal fragment. There is another way to do this in this radial divergent way, and there is a similar like the first one, a cross Kircher wire, but also only from the radial side. But again, remember, always needs a perfect reduction, otherwise you cannot get this stabilization with Kircher wire in a proper way. Remember my first slide I have shown. What is the problem in the fixation? Not only in the reduction, but also in the fixation is the anatomy at this region. You know, the elbow or distal humerus is very fine between the shaft and the capitellum because of the olecranon fossa. And to go or to pass with the Kirschner wire through this hard, narrow area is very difficult. And again, if you have no rotational failure and you start to fix this elbow in rotational failure, it's very difficult to get a good stability that you have a fixation, a bicortical fixation of both fragments. If you have a good rotational correction and you go through the fossa olecrani, as we have to do this sometimes or mostly in the monolateral divergent technique, you get a good fixation. But if you have rotational failure, then you will fail. So, first of all, the first technique, the traditional technique, I guess worldwide most frequent technique, is the crossed bilateral Kirschner wire fixation of such a fracture. On the left side, you see the displaced fracture. This is a bone model with physis of an 11-year-old child. You know, the most frequent fracture we have around 4, 5, 6 years of age. That means the bone is much smaller than we see this on this model. Then, okay, the first step is reduction as we have seen before, and maintain the reduction with the hyperflex and pronation of the elbow and pronation of the arm, as you can see here. The next step is then the planning. Of course, this is the good planning. We will fix from radial to proximal ulnar side and from ulnar to radial side. And as you can see here, in both pillars, on the ulnar and the radial pillar, and the crossing point is highly over the fracture. And all these are in one plane. So here now you see how we perform this. But on the left-hand side, as I will show you, there is a problem. What is the problem here? You see the drill machine is here. My entry point is here. And you see there is a long distance of the of the Kirschner wire. And when I start to press, not in an actual way, I bend the Kirschner wire and I will not end up as I planned before in this way, because my planning point was here and not here. Therefore, I recommend, as you can see on the right side, that you bring the drill machine much closer to the fracture. That means the distance of the Kirschner wire, keep it as short as possible. That guarantees that you end up in the correct way. On the other side, you know, you bend the Kirschner wire on axial pressure. You see here in this way, then you end up at the correct point. Here you see it again. You see a short distance of the drill machine to the skin. Here we have a nice picture in a hyperflexed elbow AP view on the C-arm from John Dwyer, who is typing your answers. And he always start first with the lateral Kirschner wire. Why lateral Kirschner wire? As we remember, the lateral column is nearly 60 to 70% of the surface of the square of this region, and therefore, when you fix once this, you get the higher stability. Okay, this is the way to do this. Okay, and you should end up here on the cortex and not outside here. Okay, here you see a clinical picture, how it performs this, hyperflex of the elbow and the Kirschner wire on the intensifier, you see very nicely and well aligned. Here again in the model, and what I will focus here is exactly how to perforate the cortex. You have to perforate the cortex. If you end up here in the bone, there is not the high stability. Then you start on the ulnar side. But this is critical. That means beware of the ulnar nerve. And we will discuss this now. This is important to recognize how to do this, especially when the elbow is swollen. Okay, here you see such a hyperflexed elbow. The Kirschner wire is on the skin from the medial side. But please do not this in this way, as you can see here. What is the problem? You know, the problem is the ulnar nerve who flips over the medial epicondyle. Therefore, we recommend to open the elbow, that will extend the elbow to relax or release the ulnar nerve from the medial epicondyle. This is really important. This is also the recommendation which gives Mercer Rank in his book. So this is the problem. You see, this is my entry point here, the planned entry point, but I have a swollen elbow. I cannot palpate the epicondyle. So what I can do then, I can make a small incision, perhaps. I can visualize the bone. I put the Kirschner wire on the bone, and then I advance this. I have not to visualize the nerve. What is the effect of the extension? As you can see here in this animation, that the nerve is relaxed and the nerve goes backwards, back here, backwards, and we have no stretched nerve over the epicondyle, and then you can enter your pin in this way. Okay, here you can see this in the picture from John Dwyer, how he do this. Extend elbow, medial wire. This is also a law. Okay, and then you fix it this way, and you see very nicely fixed crossing point over the black line, which shows the fracture line. Here you see the clinical picture of this procedure, how to do this. You see, he makes also a small incision here on the medial side, and then he performed, and you see very nicely here, the elbow is relaxed and slightly extended, and then he performed the medial fixation. So, in summary, you see, then you should end up in this very nice montage. That means in the one plane, in the coronal plane, it's one plane, and here in a perpendicular way, each to the other one. This is important, as you can see also in this clinical picture. I will show you later how we get such a nice alignment, coronal alignment of these pins. There is a trick how to do this. And this is the situation here in the model, how we bent the Kirschner wire and how we fixed it. Here a clinical example for John Dwyer. In the lateral view, very nicely aligned, as you can see it here, and also in the AP view, again, what we mentioned before, you see the point here, not too long, crossing point here, fossa olecrani, well aligned, all these points are perfect. So here in summary, the main crucial points of this fixation. Again, in the lateral view, as you can see here with the circle, red circle, both nails are really in the axis of the bone. You see here the fracture line of the distal and the proximal fragment have the same length. That means no rotational failure. And in the AP view, you see again the fracture line here, crossing point here of the fracture, crossing point of the fracture here in the medial column, and the crossing point of the Kirschner wire here. That is a perfect fixation in this way and a good reduction. So, therefore, when we go for this fixation technique, we have to ask ourselves about the risk to damage the ulnar nerve. What are risk factors? If the child has hypermobile joints, as you can see in the clinical examination, especially mobile ulnar nerve, as you can test on the contralateral arm, or the child presents with a ulnar nerve damage or problem, then you have to consider, is this technique really good or not? Okay, therefore, you have to think about other techniques. 2 lateral pins, or an X-fix, or for an open approach. Okay, so we will go on the next technique. Once we have get a good fixation, of course, we let the Kirschner wire outside, as you can see here, and the patient needs a long arm cast, and we hope we end up in this very nice result. Coming to the next technique. The second technique is now the crossed radial Kirschner wire fixation, as you see. Of course, as I have written here, with this technique, we can prevent ulnar nerve damage. Even we we perforate the bone on the ulnar side, we push the nerve away from the bone. But there is another risk in this technique, as you will see in a short moment, because the radial nerve. We have to take care on the radial nerve, and therefore it's important which is the correct entry point for the proximal wire. So beware of the radial nerve in this technique. Even it's a fantastic technique, very easy, only from the radial side, gives a high stability, but be aware of the radial nerve. Here we go shortly to the technique. Reduction again, as you have seen before. This is the same approach, and the planned situation here to fix this in this way. Here the clinical situation on the X and the picture for the bone model. And again, now look about the entry point. Again, good fixation here is important. Entry point of the proximal pin never, remember what I said, never higher than 2 centimeters over the fracture zone. Then you can be sure that you do not damage the radial nerve. This is important and the key step of this operation. Of course, then we will see this situation. Again, 90-90, this is important, one plane, bending of the pins, and again, of course, pin care is important, plaster cast, and we hope we have a good result. Now, the third technique is the divergent radial Kirschner-wire fixation. With this technique, we can prevent ulnar nerve as well as radial nerve damage if you make it in the correct way. But you must take care, because with 1 or 2 Kirschner wires you perforate the joint, and you must take care that you get no infection. Again, this is the critical point in this technique. Be aware of the joint perforation. So, you know these pictures from before. The steps of reduction is absolutely the same. You need a perfect reduction to get in this to apply this technique, and you see here the planned Kirschner wire fixation. The divergent technique one goes very high, and one crosses the olecranon fossa to the contralateral cortex. Here in the clinical situation and the model, you see it in the same way as before. You see what is crucial, and this is important to fix it, as you can see here. What is important in this technique? We need to fix 4 cortices, and you can do this by crossing the fossa olecranon, the olecranon fossa here with this Kirschner wire here. This is important, as you can see here. Of course, also in this technique, we remain the ends of the Kirschner wire which are bended outside of the skin. And we have really no risk, but low risk of damage of radial and ulnar nerve. Again, also this technique needs a good protection of the Kirschner wire, needs a long arm cast, and we hope we end up in a perfect reduction. Now, according to this technique, I will show you how we can teach this fixation technique and how we can reduce the stress in the OR. First of all, as you can see here, we are working here on a free arm table. Again, it's a left arm, and the arm is rotated externally, as you can see here. In the next step, we visualize the midshaft axis of the humerus with a Kirschner wire, and check this under intensifier that we have the long axis of the of the humerus, as you can see here very nicely. You see the fracture is not reduced up to now. Okay, this helps me to get this coronal plane, as we mentioned before, that I have one plane for the Kirschner wire. So then we make a line drawing from the inner side, medial side, to the lateral side, as you can see here. This is important that we visualize this line. And in this picture, we get this from Rick Reynolds, who propagated this method. You see, then you extend the line around the elbow to the lateral side. This is the plane of the humerus. Then we switched over to an AP view. after good reduction. And then you see these two crossed lines show the direction of my Kirchhoff wires, as you can see here. So entry point must be on this level, and these are the lines for my Kirchhoff wires. Okay. So then you see you can start, and as long your drill and your Kirchhoff wire goes along these lines, you have a guarantee you must be in the bone, as you have a good reduction, and the fragments are well aligned, and you have a good fixation, as you can see here. This is an important point. And again, pins capture the far cortex, especially in this technique. This is absolutely crucial. Otherwise, you will have a loss your reduction even in the plastic cast if you have not a good fixation here and here. Okay, here you see again a picture from John. He did this in this way. Wires cross outside of the bone is crucial. Fore cortex are hold. Engaged far cortex. One is a little bit too long. You see, I don't like this to see it this way. Then you can pull it a little bit backwards. I guess it's safer. And we fix mostly in bigger kits or bigger bones with 2 mm Kirchhoff wire, but we can do this also with 1.6 and widely divergent at the fracture side. You see these points again here. So once we have stabilized this fracture, we have to test our stability. We have to check, are the wires really divergent or are they parallel? Are they widely divergent? This is important, as I mentioned before. Go see to the fossa olecrani. Wire engaging four cortices, especially the distal wire. If not engaging four cortices, you have to redo this. Otherwise, you have no guarantee for good stability. And again, in smaller bone, up to 7 years, you can use 1.6. In older, we recommend 2 mm chi-wires, which gives higher stability. And the fixation should allow a good functional testing. It should not be, we call it visual stable. So, in addition to this, we have to think about the fracture configuration, where we have the fracture. If the fracture is too proximal, this technique with the Kirchhoff wire is critical, because then you end up with your crossing point directly on the fracture line. Or when the fracture is very distal, this is also problematic for especially the monolateral divergent fixation. Or you have a very oblique fracture in all planes. Kirchhoff wire fixation can be difficult even if you get a good reduction. But every time you start to push the wire against the bone, your fracture will dislocate. Or you have fragmentation of the fracture. Then we have other options nowadays. So the next question is then, in all this fracture, the timing of the treatment. There is a paper from Cincinnati. You see, there is no worst outcome if you delay more than 12 or 20, 18 hours, but they do provisional reduction. In our clinic, we go in the same way, but we fix the elbow only in a plaster splint over the night in a comfortable way that the patient is pain-free. Of course, if you have vascular problems, you have to exclude this, and in the study they were excluded, and they included Gartland 3 and 2 types. There is a paper from Glasgow. There is also treatment delayed to the next available list on the next day. There is no outcome difference when you are within 12 to 14 hours. There is another paper from Edinburgh with 170 fracture, Gartland 3 fractures. You see, up to 8 hours delay, they had open up 8 hour delay. They had up 18-hour open reduction, present open reduction. If the delay was longer, they end up to 33%. If there were no delay, they had only 11%. But nowadays, we have learned a lot about reduction and fixation of these fractures. Therefore, I guess this number of open reduction, even you are in delay, could be reduced dramatically, as we know from other papers. And these are other papers or a series. You see here, in Glasgow, they had 19 fracture a year, and they had up to 25% of open reduction. And Edinburgh 18, Cincinnati 8%. But our friend Rick Reynolds in LA, who makes nearly 70 fracture a year, he has only 3%, and our own cases with 42 cases a year, and a lot of experience, we have only 3.5% of open reduction. So this is a question of skills and experience in this treatment. So I have a question for you. What wire configuration do you prefer now after my presentation? Through cross wires, to lateral wires, or other configuration? Please, your vote. You can vote, and we will discuss your voting later. We give you 10 seconds for this, or 15 seconds to do this. So we have 16, 17 answers in one, and we have nearly 100 answers. That's fantastic. Okay, I guess we can show the results. Everybody see the results? Okay, 2 cross wire, still the majority, double of the 2 lateral wires, but even then we have 1/3 of all, they have the lateral wires. Can we go back to the presentation? Now, I will give you some explanation about this. Here is a study, crossed or 2 lateral wires. They found out no difference in fracture position. Of course, fracture position is a question of reduction, of course, and fixation, and how do you apply the plaster cast. But there was no difference. But you see, ulnar nerve injury, if you fix it in flexion of the elbow, that means if you go for cross wires, mostly you have flexed elbows. I showed you, you have to extend the elbow to do this. If you do this in extension, you see, you can decrease ulnar nerve injuries to 4%. But if you go to 2 lateral pins, you see there are 0 in 0, and these are 345 patients. You see here a meta-analysis, nearly more than 5,000 cases between cross wires and 2 lateral wires. First of all, they were looking about the deformity after healing. There is a little bit visual difference here, that we have more deformity in the lateral wires, but this is not significant, statistically significant. But if you are looking on the nerve injuries, statistically significant is this here, that you have a really higher rate in the crossed wires. You see here, and the most of them are ulnar nerve damages, as we have seen before. But even here, we have some ulnar nerve damages. The another meta-analysis here, the iatrogenic ulnar nerve injury is 4.3 times higher risk when retrograde cross wires. But no loss of fixation or deformity, there is no difference. So, for the moment, this is my presentation, and I will give over to my to John Dwyer. He has summarized question. He has answered some question to you, but now we can discuss some question in addition, some burning question. Please, John.